Hello, everybody. Welcome back to our next session for our Ontario Network of CAPC CPNP projects online conference. And I'm really delighted to welcome to our conference Elsie Amoako, who is here from Mino Care and is going to speak to us about culturally safe perinatal care programs. Welcome, Elsie. It's really
Hi.
great to have you here.
Yeah, no, I'm excited to be here and I'm excited to share more about the work that we were doing. I think it's going to be a really interesting conversation around system design and kind of
Okay.
like how we can integrate culturally safe care into that and what it looks like when you're developing programs like ours, in partnership with CPMP programs.
Excellent. And one thing I forgot to ask you before we started is I'm happy to gather questions for you for the end of the session, unless you'd prefer me bring them to your attention as you go. Do you have a
Yeah,
preference?
I'm gonna save time at the end where if anyone has questions, we
Okay.
can go through all of them. Yeah.
Okay. Sounds good. I'll be here if you need me, Elsie.
Okay, awesome. All right. Well, hi everyone. As it was mentioned earlier, my name is Elsie Amoako. So I'm the founder and CEO at Mino Care. And Mino Care used to be Mommy Monitor. So some of you guys may know us, some may not. There's a few people who probably possibly referred their patients to us. But we are a holistic virtual perinatal care center. And we essentially provide wraparound support to patients who are referred to us from different institutions. And the wraparound support, I'll talk in a moment a little bit about kind of like what that looks like and what type of services we offer. But I always like to start off by sharing a little bit about what Mino means, because some people are probably like, why did you just change from Mommy Monitor to Mino? What does this mean? Mino is, if anyone's ever seen Black Panther or if you've ever seen The Woman King, Mino are the women who are protecting the king. And the Mino were the warriors. And historically, they're called the Dahomey Amazons, and they were based in what we would call today modern day Benin. And at that time, it was women who were raised to be warriors to protect the king. And many of them didn't actually birth, which is very interesting. The majority actually didn't actually birth. They dedicated their life to service, but they were still seen as or called Mino, which means our mothers. And the community called them this because they were seen as advocates, they were seen as protectors, they were seen as mother figures within the community. So after rebranding and really thinking about who we realized that's who we were. We were advocates. We were like we're there for the community. We were a figure to a certain extent, and so that's why we changed our name to Mino Care. So just a little context so you understand what the name means. And as far as like the foundation of what we do is based in and completely centered in health equity, reproductive and birth justice, ensuring that we're honestly in the space where we can eliminate anti-Black racism within the healthcare system and any type of racism, really. And then providing culturally respectful and culturally safe care and supporting institutions to be able to do that. So that's the foundation of who we are as an organization. And everything that we do starts with these things and ends with it. And our anchors are innovation of choice, which is just saying that we want to put choice back into the hands of patients, and providing culturally safe care, which is saying we want to remove the hierarchy and ensure that healthcare is a space where people experience kindness and they feel safe and there's no bias or limited bias and understanding of people to their core at an individual level. But then at the same time, we have our full circle of care, which is a model that we developed that explores it's the connection between clinical, social, and family engagement and how we include the family in the care process. And then protecting data for access, which is just saying that we want to ensure that, especially for the Black community in particular, because we don't have any real guidelines or policies that kind of enforce how our data is protected and secured. Just thinking about how we give access to data to patients and to individuals who are asking and want their data, and how we protect data for populations that are more vulnerable. And our why, I include this just so people understand the context in terms of where we come from and why we do what we do and the purpose of this. And again, the purpose of going through who we are first is so that you understand the program later on and the things that we'll discuss. But for me, really early on, just doing research and engaging people that I knew who worked in the healthcare space, we knew consistently that we were seeing the same thing, misinformation or a lack of information. So that could be anything from like limited prenatal programs or no prenatal programs in some provinces or whatever that looks like. A lack of access to services and it was always kind of ironic because it seemed like there was multiple programs available, but people weren't accessing them and understanding that issue at its core. And then also understanding that though there was a serious lack of culturally safe care, and not because people didn't want to provide it, but because it's just difficult to provide because you can't know everything about everybody's culture, right? And you can't identify cultures and traditions and habits and things that people do that impact their care, their health, right? Unless you're an individual who may be from the same culture. So, and then just general limited support. And this is specifically, and this is like social support. So people not having family or friends or community to kind of sustain them and support them when they're pregnant or when they're trying to get pregnant or postpartum. So these are things that we really identified. And then, of course, research also tells us Black women have worse outcomes, which we've seen consistently in data kind of globally. In Canada, obviously, there's limitations around our data. We don't know what the Black experience looks like, but we know from smaller studies that it's pretty consistent to what we've seen in the US as far as experiences, not in its full scope, obviously, because we have different healthcare systems, but even in the UK as well, we see similar things. And then healthcare institutions that are overwhelmed. So we know that our just generally, healthcare is overwhelmed in most countries around the world, and Canada is one of them. And we're not dealing with a medical desert in the same way as like France is dealing with it, but it is still quite bad here in Canada. And the level of high-risk patients we have, or patients that are more vulnerable, is continuing to grow, especially with the high number of like refugees and non-status individuals who are moving to Canada, and us not understanding, or the healthcare system in itself or institutions not really being able to figure out how to properly serve them because of an issue with system design. So, more than anything, what I've recognized over and over and over again is that our system isn't geared towards the needs of like the Black parent community in Canada. And I think that's evident. But for us, our mandate consistently is restoring choice, right? And ensuring that we are kind of moving in the space of birth justice specifically, and ensuring that people take control back over their bodies and their data and their information and everything that has to do with their healthcare. And that's where our beliefs stem from. More than anything, we want to ensure that every patient we work with is heard, that they feel like they've experienced humanity, that they're informed of all options that are available to them, that they're respected, that they are in a space where they can make decisions for themselves, right? Where they can choose who's around them and who provides care to them, where you believe everything they say when they tell you, when you support them and give them all the best care options that are available, and that they're informed, like more than anything else, right? So that this is the the depth of who we are more than anything else. If we were to talk about who Mino Care is this in a photo, which is why I shared this so that you guys can clearly understand how we function and how we design our services and our care, and where it all starts from and how it all ends. As far as the services we offer, so we offer various services. Like I said, wraparound support. Our maternal care navigation is either a midwife or a nurse that has like an hour with patients to kind of allow patients to ask any questions they have, and they also do prenatal and postpartum kind of education. We do mental health support. We have a variety of different psychotherapists and just different people who provide mental health support services, therapy, or counseling. We provide childcare. Childcare is really cool. We did a partnership with Unison, and they trained some women from community, and we hired them to provide childcare, and they've been providing childcare services to various patients that we work with, and which was a great model, and very cost effective. We've just added sexual health, and we're going to be doing a lot more work around that. And soon, hopefully, we'll be able to add pharmacy as well. But we also provide doula care, lactation support, fertility support, pelvic floor therapy, dental care. We have a dental hygienist who goes into the houses of the individuals to provide services, pregnancy massage. prenatal postnatal education. We support them to find other services if needed. We have our caseworker that also supports all the patients and follows up with them and engages them throughout the process. And respite support specifically for single moms or moms who are giving birth and don't have anyone to watch one of their children or their children if they're going to be in hospital and they have no family to support. So like overnight care and that kind of stuff are things that we're also providing. Developmental screening is on pause now, but we did provide that in the past, and we're developing a new program around that as well for observational and developmental screening. And then we have our workshops that we do, which are just more based on education. And in terms of who we serve everyone. We prioritize people who are the most vulnerable and have the worst outcomes, specifically the Black population, but we and other racialized folks, but we get everyone and we never turn anyone away. For us, our patient journey, it starts with people getting an intake form from their through their healthcare provider or their social worker, whatever professional is working with them. And then once the intake form is filled out and sent through our website, then we receive it, we assess it, we engage the patient with whatever services they've requested. But then we also follow up with them, whatever professional we connect them with, which is typically a professional who is from either a similar background, ethnicity, or speaks a similar language, or just has some type of connection with the patient in some way. If not, we have an interpreter that we'll include to support the patient better. But the goal for us is to understand who the patient is as an individual level, which means we want to know who they are, what their habits are, what foods they eat, all the things that kind of make them who they are, so that we can understand what type of potentially bad habits they may have, or if there are things that they're doing that are causing adverse outcomes that are natural, but for some reason in this context are just turning out adverse. So for us, it's just trying to understand who they are to better support them. And so the contracted professionals that work with us, they give us constant updates to tell us what's going on with the patients. So we have that information, and then we use that information, all this data, to just continue to recommend other services to the patient if they want it. And the patient can opt in or opt out, but it's available to them. And patients usually stay with us for up to 2 years, especially if they come in pregnant. And they, after like postpartum, they kind of continue on with pelvic floor, mental health usually. And then by the end, they probably are just continue with mental health support, and then they kind of wean off of our program. So that's kind of like how we've engaged patients and what that looks like. So for you to get a good grasp of what the project with Parkdale Queen West was like, you have to understand kind of like how we function as an organization. So that's how Mino Care functions. And now we get referrals from over 20 different healthcare institutions throughout Ontario and some of the and in Quebec as well, and very small amounts in other provinces. We're not national yet fully, but hopefully we'll be soon. But what was interesting to me is the constant kind of conversation around what does it look like when we formalize these partnerships that we have with institutions that are referring their patients to us, and specifically, and we were looking at different models. And one of the models in particular is this model. And we have a platform, we have a technology we haven't launched yet, but haven't launched it because of capacity reasons, clearly, because we didn't want to take on too much, especially with a small team. But we first thought one of our options was technology, obviously, in terms of like a general referral system, which is something we're building in now. But then the other option we thought was this, like working within an institution in partnership and what that looks like. So with Parkdale Queen West, for us, we had conversations around the high number of Black refugee patients that they had and their inability to be able to support them at the level that these patients needed. And these patients are in a space where they obviously were unhoused. Many of them were not obviously, but many of them were unhoused, unfortunately, and some were living in shelters and hotels. Some in some cases homeless, like living on the streets. But then in addition to that, always realizing that many of them were coming to Canada and immediately needed care. So it was kind of like care was kind of like at a last minute type of situation, which was difficult at times. But then at the same time as well, they also needed lots of social services and supports. And sometimes they weren't connected at all. And obviously they didn't understand or they don't understand how to navigate the system. So they're not accessing services and they're kind of just showing up at the door and like, my friend told me about you guys. Like, can I have some services or some support or some care? Not knowing what they really need, sometimes not being able to communicate it, but just kind of being in a space of like, I need help. And then it's up to the CHC to then kind of, or the program, like the 5Ps program at Parkdale Queen West, it's up to them to then kind of figure out how they can support that client and how to better provide them whatever it is they need, right? So that's where we came in. And before I talk about where we came in, I wanted to talk a little bit about kind of like the experience of these patients. So as I was mentioning, coming into the country, obviously as a refugee or non-status person, you're dealing with a variety of social determinants that are impacting your life, and everything from not having work to dealing with how a lack of housing to dealing with not having food. Some people would stay with friends and family, and or in the that this the issues that can be connected to that, the power issues, the imbalances of living with somebody else or being in a space where you're in a country, if your husband brings you to this country. And there's some people, some women in particular, who maybe didn't speak English and their husband would speak on their behalf. So not being able to communicate their experiences, sometimes, and just like all of the various things, not having transportation, not having food, in some instances, not having, like, there's a variety of things, right? Childcare, you can, like, you name it. And they typically were probably dealing with that. And so being aware of that disparity, is very, very important for us at the jump, because we have to understand how this disparity translates to what the system offers and how what that route looks like for these patients, because each patient will have a different experience. And so we have to kind of recognize that how to kind of customize it to each individual to a certain extent to ensure they're getting the full scope of support so they're not ending up in an acute state. So these are all things that we have to think about consistently. So like I said before, this is like, apart from status, just literacy, disability. There's a lot of people who come into the country with disability. There's a lot of people who come into the country just generally just not really having any understanding of kind of like how the city works, or how even the subway, anything works. So just understanding all those things ahead of time, and then also understanding policies that make it even more difficult for them to function within the healthcare system because of that, because of their status. So what we did is we used a combination of models to develop a model that made sense, which is like the guided care model, the full circle care model, which is ours, is safe mom, safe baby, nurse-led interdisciplinary clinical model, and the cycle to respectful care theory. And this combination, in addition to, is kind of like was a representation, a mix of what Mino Care does, and then what we thought could work in this space. And so the guided care model is a model that where there's a team that includes a specially trained registered nurse and physicians, and then primary care staff. The full circle care model I spoke about earlier on was the clinical plus social services plus family engagement and informed involvement of the family within the process, which is something that we do at Mino Care specifically. And the SMSB is a nurse-led interdisciplinary clinical program, and it was created specifically to demonstrate kind of like the power of integrating services for clients is who are specifically experiencing intimate partner violence. And then the cycle to respectful care theory is great because it's a step forward from, or it's a step beside culturally safe care. It's kind of like the cousin of culturally safe care, I guess you could say. And it specifically was developed to focus on the Black woman's experience specifically. And it just talks about being intentional with patient engagement, advocacy, and making sure that we're kind of addressing birth equity within maternity care, and that we're really looking at all of the things that we talked about earlier on as far as the social determinants of health and those factors that impact somebody's life, their full intersectional experience, but looking at that intersectional experience not just from the perspective of those factors that impact their lives, but also looking at it, how those factors integrate within their experience within healthcare, especially specifically maternity care, and looking at how healthcare systems and providers are working towards supporting those things, and those understanding those differences that are occurring because of those experiences and those factors, and how they can make a change that includes those things in the process. So for me, that was really important to kind of pay attention to as well. And this is a better look at it. So this is kind of like the end result, I would say more so, where as an institution or you're recognizing, okay, what we're doing is we want to implement change with the provider community, right? And addressing equity and being accountable, right? Then coming together with the community, coming together, and then you're deciding that you want to transform institutions, you want to create change, a new culture as an institution, and then you maintain that. And like, and the beginning is getting ready obviously and realizing that you need to make the change before the implementation, but like just is kind of like how do you make an intentional um or intentionally decide to make a change within your institution, and how do you maintain it essentially. And what I love is that, like I said, it's like a cousin to culturally safe care, because we are starting from awareness to sensitivity to competence to safety. But what I love is that within the healthcare setting specifically, what that looks like is building trust. What that looks like is fostering humility. What that looks like is demonstrating respect, right? And that's how we sustain change long term. But for us specifically, what it looked like was sharing knowledge. It was hiring professionals of different ethnicities who speak different languages and have different religions and cultures and experiences. And what it looked like was ongoing patient follow-up care and supporting them. What it looked like was community and patient engagement, right? Within the clinic and outside of the clinic, right? Understanding the jurisdiction that you're working within and understanding the area and the population there and their needs and who they are, so that when they do come into your space, you can actively support them in a way that's intentional because you already understand the context, and then also hearing them to be able to add on to that. And for us, this is what culturally safe care looks like, specifically when you're kind of engaging the Black community. So for the project, we partner with Parkdale Queen West, and what it looks like is that we were going to offer customized support to the Black refugee families through referrals that were coming from like them and GST as well, and other neighboring surrounding spaces. And so what we were going to do is increase our staff time. So what that looks like for us is we hired staff specifically to work within Parkdale Queen West, like once or twice a week, and then also do virtual sessions with GST and Parkdale Queen West as well, and their 5 Ps program there. So we hired a nurse, and the nurse became our coordinator and care navigator. And I mentioned earlier on at Mino Care, we have a maternal care navigator, a program, I guess you could say, or and that looks like just kind of creating space for patients to come and ask any questions that they want. And so that's what it is. And but then in addition to that, she's also our care coordinator. So she also coordinated care for those patients in that space, ensuring that they got what they needed. So what I love about this is that now we're integrated within their system. So we have somebody on site who can talk to their patients, who can build relationship, who can engage them, who can hear them and learn about what their needs are, and then be able to not only provide them with clinical support or advice, but in addition to that, be able to recommend services that would be best for them by listening to their individual stories and experiences. Uh, but then in addition to that, we also looked at, well, clinical support and services is a huge part of what we're offering. We all offer together in partnership. And the Parkdale Queen West was still continuing to offer like housing support and clinical support and all the other things like social services and other things in addition to what we were offering. So it was a combination. So and I have a later on, I'll kind of break down what that journey, like what that looks like, how it worked, but they would offering that. But then in addition to that, they're also offering like food cards, pretzel cards, diaper, formula, clothing, a welcome basket that includes a number of these things, and a food voucher, which we provided to the people in the program. And then in addition to all of that, we also are doing 2 training programs, which is we haven't done yet, but we're going to be doing later on, which is going to be focused on more the details around how to care for Black refugee patients through this system, and kind of like what you need to know, and services you need to be able to be aware of, which is something that we're going to be doing later on. So how it starts off is that first there's a care referral, like I mentioned earlier on. So we created actually a separate link for them for them to be able to refer their patients. And we did that to separate from our general Mino Care kind of like client base because we didn't want to kind of combine those two so that we could track this data and information and we know which patient's coming from where and kind of like what their outcomes look like and who's working with them, et cetera, so that we can manage, organize, and track that all much better. So they had their own separate kind of login and stuff like that. And once they refer a patient, our coordinator finds out about them right away. And once a coordinator has that information, obviously she organizes them and then she works with the 5Ps team to provide them with a welcome basket that we talked about earlier on, and then the food voucher, which is the third step. And once the client has all of that, at this point, they've already been connected to services. So whether that's doula care or pelvic therapy or lactation support or whatever that looks like, they're already probably using that service at this point. And then we provide an update to Parkdale Queen West. And from there, then Parkdale Queen West, they'll know, for example, if we're working with a client and we find out that the client is living in a shelter and they need housing support, that's an update that we can share with Parkdale Queen West. And then Parkdale Queen West can then go ahead and provide that client with those extra services and supports that they need. And throughout this time, what's ongoing is our team, our coordinator, providing those workshops with the patients and care navigation ongoing. And then also the professional training that we talked about, which is the two sessions that we'll be doing later on. But this is kind of like what it looks like. And it seems like it doesn't seem super intense. But I think what we realized over time is that what the patients need and how the system is designed and how the CPMP programs are designed and what it looks like and how we fit into that, that was interesting to me. So like I mentioned earlier on, I mentioned some of these things already, workshops. We worked with 50 clients. So we were funded through the Black Health Fund, through Ontario Health. And so the budget called for 50 clients and it was about 2,000 each, which gave them access to the use of 4 services, up to 4. Not everybody uses this much, but this is how much we budgeted for each patient, just to make sure that there's room for them to receive as much care as possible. All of them use doula care, whether postpartum or full spectrum, but it's always doula care plus something else. So doula care plus mental health and dental hygiene, or doula plus pelvic therapy or childcare. It was always in combination with a number of things. And we ended up at the end serving 63 clients so far. And we're kind of finishing up with a few of them. But for, like I said, the main services that were used were doula care, lactation support, dental care, mental health, et cetera, et cetera. Um, and what we realized is that some of them worked with us from 1 to 6 months. So some people came to us right as soon as they were about to give birth, like literally a week or two before or whatever. And then they got support. Then they're like, my mom's here and I'm okay. I don't need anything else. And some people were like, I need more. And we were with them for up to 6 months where they continued to use other services. What I think I realized is that like the biggest challenge for us was ensuring that we were creating access to the other racialized clients because we got a lot of referrals for all clients on site. But because the funding was for Black refugee patients, we didn't know how to navigate what to do. So we didn't turn people away, but we tried to create space, but we realized that if we're doing this again, we have to open it up to ensure that we can give access to like all the clients that are racialized in the space because there was a lot more that needed support. And the other thing that we realized over time is that the coordinator or the navigator that we talked about, the nurse that was working with them, that she needed to be around them more. She needed to be around the patients more long term. She needed to build trust. A lot of the patients didn't know what a lot of these services were. They didn't even understand if they could access it. They didn't understand if they wanted to even. Some people would sign up for things and then would just change their mind later on. There was like all that kind of back and forth, and we realized we needed to be there a lot more. We needed to engage the patients a lot more. We need to build trust. And this is something we learned early on with Mino Care as well. Really early on when we started, it was difficult for us to kind of engage patients or get them to use the services because they just didn't trust us. So it took years of us just going back and forth and kind of encouraging their healthcare professionals to who referred them. And then once the people were using services and they saw that it was efficient, that it was effective, that they could trust it, that it was available, that it wouldn't disappear in a year, then they kept coming back. Then they would tell their friends and their friends' friends. And that's why Mino Care has the large patient population we have now. But for a program like this, because these funded programs are so short-lived, it's difficult to build that trust. So that was something that we thought about that, and I think we're continuing on with the program, but for now, looking at how we can kind of extend that and build community and build engagement within the five Ps program for their patient population there. But I think more than anything, what we realized the benefit over time was like we increased access to services for these patients, right? We gave them a lot more. They had better health outcomes. They increased engagement. They people could just make decisions for themselves, could share information. They had interpreters. They had options, right? And we were reducing like patient load, right? Like the load that is on the CHC and on professionals that they can't deal with. We were reducing that because we're taking patients off their hands and kind of supporting them. These patients who are more vulnerable and high risk, they now have a support system that they didn't have before, right? Which was interesting. But I think more than anything, the main thing that I realized is that the biggest difficulty with developing programs like this is the fact that there is a larger system design issue. And that I was looking at some of the recommendations from the 2019-2020 CPMP kind of there is a report that was written, and I was looking at recommendations, and one of the recommendations they said was like you guys need more program design, like more models, more new program design models, right? And I realized a part of the issue is the fact that for us specifically in Mino Care and how we can integrate with Parkdale Queen West is that we can integrate at a surface level because we're a separate entity and we can kind of bring in our own kind of like our own ideas around integration and tools and information sharing and what we think works and try to kind of add that as a part of the process. But there's only so much we can do, right? Because at the end of the day, we're not fully connected or engaged in the process of the CHC overall. So how can we as an organization fully and properly integrate and ensure that the information is shared appropriately, ensure that the processes is more effective, ensure that like the structure function, like that structure function relationship is as great as it can be if we're surface level. And I realize it's not an us thing, it's a system thing. And I think that the problem is that ideally we could have interorganizational partnerships, right? We could have a care referral model that looks like that, that looks like us setting up a program like this and doing it with every CHC, every CPMP program throughout Ontario, where we're doing the same thing with everyone, right? But I thought about why it wouldn't be effective, and it's a design issue, a system design issue, and that was unfortunate when I was thinking about that. But in addition to that, I also realized that there still is opportunity to scale, right, this model and do it nationally and try and figure out and continue why it worked and continue to think about why it works. And it's because of our kind of shopping bag method. Like people can kind of just come in and choose what they want and kind of go back and they have choice. And that feeling of choice kind of allows people to feel a lot more secure with their healthcare and feel like they're in control. And that was something I realized. In addition to that, like I mentioned earlier on, we integrate culturally safe care throughout our process. In Mino Care, we're doing evaluations from the beginning to the end. So from the intake form to after the person has received their services in terms of receiving data from the professional who's been seeing them, to checking with the patient via phone, doing follow-up, to the caseworker checking in, to calling the patient ongoing, and just we are constantly monitoring the situation and trying to evaluate what care is looking like over time. What are the changes that are being made? Are we seeing a change in the patient's health over time? Are what services are effective versus what's ineffective? What is needed, right? And because we can do that, and because we can kind of explore what is needed and learn more about what the patients want, it gives us the opportunity to be able to provide more culturally safe care because then we understand, oh, we're working with a large Eritrean population. So we need these key things. Something that we're doing now or that we're just starting to, we talked with Regent Park CHC, Community Health Center, and Regent Park just did a doula training program in the community, and they trained a lot of women from the diaspora who speak different languages and may not have as much doula experience, but culturally understand birthing methods and birthing traditions from these various cultures and countries. And the number one feedback that we got from Mino Care is I want someone from my country who understands how we do birth back home. I just want them there. I want them to be able to support me. They don't have to perform anything, but just understanding what I'm used to is what I want to see in that room. So for us, we realized we can hire these lay women who have been trained as doulas, and they may not even have to provide full doula support. We can have other doulas in the space who have more expertise, but we can have them in addition to them who can just understand, like if they're from Eritrea and they have that background and they know how they give birth back home, just having that person in the room makes the patient feel more comfortable. So that is another model that we've just started adding to our work as well. Another type of doula that we're looking at, like a cultural doula that we've just started working with, which is really exciting. And we just signed them on, so they're gonna start working soon. But that's just something we think about as well. And then I thought about as well, like integration of technology to organize and manage care. For us, with this program in particular, we just use the system that we have at Mino Care, which is centered around data collection and it's centered around like I said, like we have steps that are quite clear. It's like intake, then from there is patient updates and information and data shared back with us. And then it's patient follow-up, which is more data that we collect there. And then the patient ends their kind of experience with us. And so that full spectrum of information that we have is information that we also share back with the patient. So the patient has an understanding or an idea of what their care experience looks like. Well, in our technology, that is so that they know what their care experience looks like, and then they can look at it and read it and engage it. But they can also share information back, and they can ask questions, and they can engage their own experience of care. And so we thought about that from a patient perspective, and then from a professional perspective, like organizing and managing care. I think that's something that we still need more than anything else in our systems that we're failing with. And then the four-tier partnership model. So I saw some models that are like this, but again, trying to explore what does integration look like when we're doing care like this, but doing it in hospitals, in midwifery clinics, in private clinics, in CHCs, right? And that each organization from an institutional level is actually engaging and is sharing information and is sharing data. And how does that work? And what kind of structure does that look like? How does that function? And what does that information sharing look like? And how are we processing that? So that was something that we thought about as well. Like I thought about as well as like what is a future option? What can we do in Ontario? How can we improve care? But overall, this system design issue that we have is just it's not a program. It starts from it's not just from the programs, right? It's the institution and then it's the provincial and federal government, right? And the ministries and how they manage a lot of these things. And like obviously there's more to it, but I do think that there has to be a lot more work done figuring out how do we integrate even amongst ourselves with the CPNP programs, like how are you communicating amongst yourselves? Like, do you know what everybody's offering and when it's available and when it's not available? Do you know what kind of like patient population somebody else across town has at another program? Can you support? How do you know how you can support them or not support them? How do you know, like, you know what I mean? Like, these are questions that I feel like that information has to be shared at another level. And those are things that we thought about in developing a program like the one that we did develop. So I'm excited to see kind of like where the program goes. It's been effective thus far, and we're hoping that it will grow even further. But yeah, if there's any questions, I'll open it up now.
Hi, Elsie. We'll join you here. Maybe I'll remove the spotlight and everybody can come on. Let me just shift things around here. I will say lots of questions popped up in the chat, Elsie, as you were
Okay.
talking. So and we'll certainly hold space for people to ask more, but definitely I think all of our ears pricked up when you mentioned about this potential of training and or offering models or something for the CAPC and CPNP projects. Are you able to speak more to that now?
Yeah,
What that might look like?
yeah, so I think that the way we work, I always say we're kind of like a franchise where we integrate and we customize ourselves according to the needs of the institution that we're working with.
Right,
So Parkdale Queen West, the need was for Black refugee patients. And so we customize our program to suit that patient population.
right.
But if we were working with someone else, depending on what it is that they need for their patient population, we would adjust to that. That's number one.
Mhm.
The second thing that we would do is in terms of integration and the level of it, a level of it. So at Parkdale Queen West, we, for example, use the patient IDs so that we could communicate. Like that's just an example, communicate about patient information. And so it's what the institution is comfortable with, and then how we would do it with the institution. So with Parkdale Queen West, again, we got funding to be able to do this. So I'm always happy to partner with institutions, and then we can look at funding possible opportunities to be able to serve their patient population. Or otherwise, we can have conversations about what it could look like if we developed a formal program in their institution. But to hire staff and have them working in that space and supporting their patients, in addition to providing these services or access to these services. Like I said, it just kind of depends on what the organization needs, and again, conversation. We would have to sit
Mhm.
down and have a discussion around what that looks like.
Mhm. So it would be about connecting with the program and finding out from them what it is, what kind of support they're needing, and you would sort of work as maybe a, like consulting or supporting them in
Yeah, so we would just,
bringing more culturally safe
yeah.
practices, right?
Exactly. So if a CPMP program came and said that they have a high amount of Brazilian patients, refugee patients that are coming in, or just generally
Mhm.
Brazilian patients, right? It gives us
Mhm.
an idea of what they need by and if you tell us what their needs are, like they're requesting more lactation support or whatever that looks like. We typically come in and do an assessment first, and then we kind of take the information that you shared with us as well. And
Mhm.
then once the navigator starts to engage that patient population through like workshops or sessions, they also share like input on what they think the patients may need. And
Mhm.
then we kind of come to a conclusion and start to provide like services and support them and create a model around that. So like we have our general model, but like I said, we customize and adjust according to the institution.
I got that. And I think this next question might be related, but um, uh, do I understand correctly that you provide service province-wide in Ontario and are looking towards doing this nationally? And I think, was that
Yeah.
kind of what you were just speaking to, right? That ability to
Yes.
provide
Yes.
that support.
Yeah, we're looking now. We've been looking at Nova Scotia and where else? We've been looking at two other provinces, just kind of exploring, kind of looking at what they have available and looking at about what the gaps kind of like in that space and how we can fit and if we can support them. Before we go into a space, we do an assessment of the city and we explore like we do an assessment to find out all perinatal services they provide.
Mhm.
And then we look at all professionals that are providing services in that space. Once we have that information, we then look at what's culturally safe out of what they do offer. And then from there, once we have all that information and data, then we can understand kind of like where we would fit in that context and what we can provide, how we can be of benefit to them. And then start to develop partnerships with the institutions that are in that space. We develop partnerships with them. We tell them who we are. We let them know that we're open to them referring their patients and what that looks like. And then that's how we kind of begin working in different spaces. And we haven't done it in the other cities yet because we need a larger team, obviously. But we're hoping to kind of move towards that in the future.
Thank you. There is a question wanting just to touch base again on how you receive your referrals and a
Yeah,
question of can people self-refer or do they need
yeah,
an agency or doctor? And yeah, so is there anything you wanted to say around that?
yeah. If you go on our website, www.minocare.ca, we have intake forms there that people
Mhm.
can refer their patients or people can
Mhm.
self-refer. The intake form makes it so that you can define whether you're self-referring or whether an
Okay,
institution or an individual is referring you.
right.
Um, and in that, there's a breakdown of what services you can offer. We're about to change it soon because we're about to offer more services and we're going to be separating it. But like things like mental health support, they can actually book appointments on their own on our website.
Mhm.
We did it so it's anonymous to ensure that patients feel more comfortable. We found the Black community, a lot of patients were uncomfortable coming to us or just to people in general and asking for help and support. So we created it so that it's anonymous, so people can go and book on the calendars of any of the therapists that we have there. And if they want to, a healthcare professional can also refer their patient to mental health support, and then we just show them how to do that. But we've tried to kind of adjust to what the population needs and wants.
Thank you. There is a question about, is there a cost to get the support? And I think that's for, in terms of the people actually seeking service. Or I don't know if it's also maybe around potential partnerships or supporting, projects in their, goal to become culturally safe as well.
Yeah, it's a mix. So what I love is, and if you go on our website, you'll see we built out a professional database of all perinatal care professionals that are Black, actualized in Canada. And we have a bigger one internally that we haven't shared yet, but we've really taken a lot of time and spent a lot of years just collecting data to know who everyone is, what all services that are being offered. And that's how we're able to refer to, like, develop partnerships with the right partners and refer my patients to the right services or hire the right contracted professionals to provide those services. So it's been really great. Right now, people can just do it for free on our website.
Mhm.
You can refer your patients. If you want, there's usually a wait sometimes for some services. Some services you can access immediately, like mental health, maternal navigation. There's like a few you can, pelvic floor therapy, most of them you can access immediately. Doula care, sometimes there is a bit of a wait because so many people want it.
Mhm.
It's such a long list of people, but we're adjusting and changing that model so that we can get to more people as well. What we suggest is if an institution wants something that doesn't include a wait, then it is better to develop a partnership with us directly and covers the cost so that the patients can get that care immediately. Right now, we're being funded by the federal and provincial government and some private foundations. So we're able to support as much as we can, but even then we have to kind of be a little more careful with that.
Q. Blanca has noted in the chat that we have had Elsie visit us before, and we do have a recorded webinar in our archives that folks can look for if they're interested in more information about cultural safety as well. So I'll include that information in our resources about the session today, Elsie. There's a question here from Jen. Are there criteria for being accepted as a Mino client?
No, no, no. There's no criteria. So for me, it's just I genuinely believe everybody deserves care. Everybody
Mhm.
deserves whatever type of care that they need or that they think they need or want, right?
Mhm.
They at least deserve a space where they can speak to someone, an expert, and find out if what they're requesting or what they want is what they need, right?
Mhm.
So for us, we take on anyone, but we prioritize people who are the most vulnerable or who are the most urgent as far as their care outcome and what their situation looks like. Or if they're having multiples or anything like that, anything that makes them more urgent, we prioritize. If there's some type of genetic disposition that they're dealing with or a disability, whatever that looks like, we kind of heighten the urgency and we focus on them because of that. But nobody's turned away.
Okay. And is it prenatal, postnatal, both? It sounded like both, I
Everything.
think.
Yeah.
Yeah.
And reproductive care now. So we're now moving into the space where we're going to be doing stuff
Okay.
around fibroid care, PCOS, endometriosis. We just recently did a partnership with the SOGC and we did a project around endometriosis, which is really cool. It's on our website. You guys should check it out. But endometriosis in Black
Wow.
community. And we created a pain log book for patients and
Mm.
a bunch of other material that they can use. And just in general, we've developed other resources like a lactation and birth plan and a lactation plan. We realized a lot of our patients, Black patients in particular, were being told to formula feed and they weren't being encouraged to breastfeed. So we've developed like a lactation plan that's kind of culturally safe that patients can use to just learn about what their choices are and kind of share what they want to do in terms of breastfeeding and chest feeding. So yeah, we're trying to educate as much as we can. We have some work on the website as well around obstetric violence and helping patients navigate that experience and what they should do. And we have steps and we have a partnership with a law firm if it does get to that point where patients can get access to them. But we have steps of like how do you advocate on behalf of yourself and then how do you know if you've been in a situation of malpractice? Like how do you just determine what's
Right,
happened to you as a patient. So these are
right.
all things
That's so
they put on
important.
the website,
Mhm.
and then a lot of other education and information that's just really important.
A couple more questions. Are you able to speak to there's a question about how is Mino Care funded, like outside
Yeah.
the specific project? Are you able to speak to that a little bit?
Yeah, of course. So, like I mentioned earlier on, we're funded provincially. We've been funded with the same program for the past, I would say since 2017, 2018. That's one program we've been funded provincially. Through the ministry changed now. It used to be like the Ministry of Community, Social Services and Children and whatever, whatever. But now it's something else. I don't know what it is off the top of my head, but the program, the ministry changed. We have some federal funding now, not for services, but for research that we're doing right now. We're doing a larger study on the Black maternal health experience, and we're hoping to share that hopefully soon, before the end of the year at least. We are also we were funded by the Daymark Foundation for a bit, and another foundation as well. We're just ending our funding with, which is I'm sorry, I forgot their name off the top of my head, but they're
It's
based out of
okay.
Montreal. But the point is, we've kind of adjusted. We've moved from kind of provincial to more private funding now, and we're trying to focus on federal funding. I don't know if you guys have heard of or seen. There's an organization that focuses on mental health, the Foundry BC. We're looking
Hmm.
at their model of care, and we're looking to emulate that, where we move from virtual to hubs. And we've just kind of developed a partnership with North York General Hospital, and we're going to be opening our first clinic soon in Ontario, which is going to be great. So we're going to try to demonstrate the kind of integration with technology and in-person care and how that works. So we're excited to be able to do that soon, very soon,
That
hopefully.
was the Foundry Foundation in BC. Is that
Foundry BC. Yeah, Foundry
Foundry
BC.
BC? And they
Yeah,
have like a
no,
mental
it's mental
health.
health. It's a
Yeah,
mental health, yeah, and their model is really cool because they started off providing virtual services and then they started to develop hubs. It's a government-led program and they have it in every province. It's called something different in each province. Um,
gotcha.
but yeah, but in BC it's called Foundry BC.
Okay,
Yeah.
cool. And Lee has dropped the link in the chat there. Thanks. Couple more questions if you have time. We've
Yeah, for
got
sure.
lots of interest here. Marina is wondering, is there a newsletter list or what is the best way to stay up to date to follow
Yeah.
along with your journey?
Yeah, yeah. On our website you can subscribe to our newsletter. Yeah.
Excellent.
Yeah.
Excellent. We'll make sure I think the website is in the resource links and follow-up section there. And there was a question from, oh, sorry, I've lost my questions. This is amazing. When are you coming to Alberta? Was posted in the chat.
That's fun. Yeah, you know what? It's about partnerships. So
Mhm.
if you are in Alberta and you believe that, listen, we need Mino Care services, just email me and then we can have that conversation about what it looks like. Because us moving to new provinces, like I said, is more of a capacity thing. Our team is
Yeah,
small and I've
right.
overwhelmed them enough. So I'm trying not to kill those people, those poor people.
Right.
But like I don't
Sustainability.
yeah,
Sustainability.
sustainability, exactly. But we're
Yeah.
working really hard now just to procure long-term funding,
Mhm.
and also private funding. I'm an Ashoka Fellow as well, which helps. So some of the fellowships that I'm a part of help to open doors for some of the funding. And in the tech space, because we're in the tech space as well, that opens some doors for us as well. So we're kind of in between all things, and that kind of is allowing us to develop a model that's more sustainable.
Are there any other questions or comments for Elsie as we're wrapping up our time with her now? Gratitude showing up in the chat for you for sure. I like what Barbara's saying here. I agree. This is innovative and revolutionary work.
Oh, thank you, guys. I wanted to also
Absolutely.
say before I end that the CPMP programs are near and dear to our hearts at Mino
Mhm.
Care. We genuinely appreciate the work that you guys do. And we know how hard it is and how much work you guys are putting into it. And I talked about system design really briefly before in structure, but I am thinking about it. We do think about it a lot. I
Mhm.
really think it's important for us to look further into what these program designs, how we can improve them to
Mhm.
ensure that access increases, to ensure that we're
Yes.
using funds more efficiently, to ensure that we're engaging community more appropriately, and to
Mhm.
ensure that we can integrate with programs like Mino Care so that we can provide more support and services to patients.
Mhm.
So we're thinking about it a lot and what that looks like and how we can kind of evolve into what we see in the future or the potential that we hold. So just putting that out there so you guys know that, yeah, we definitely appreciate you guys and think about you guys. And the workshop we're doing with Parkdale for Parkdale Queen West later as a part of the program, you guys should take part. We'll be sharing it so that you guys know about it, but it'll be really cool because it'll be talking about the patient side of this. And as a like program manager or as somebody who is managing a CPMP program, it's for you guys to understand how do you navigate serving patients that are refugee and what does that look like? Like how can you do like realistically and practically?
Mhm.
What are steps? What can you do literally? So we're
Right,
gonna break it
right.
down. Like these are the things you should explore. These are the things you
Mhm.
may come into contact with. These are the things that you should have access to. And this is how the patients, Black patients specifically, are best supported. So that'll be really cool.
That does sound really cool. Thank you so much, Elsie. You've given us a lot of information. There's actually a lot to think about and unpack, which is great that we've got a recording, that we can go back and listen again, because I'm sure there's many areas too where I'm sure we could have you back and do deeper dives into.
Yeah.
I mean, I was really interested in the cycles that you shared, the recycle to respectful care, and then
Mhm.
how does that feed into your culturally safe practice. And anyway, I just really appreciate the breadth and depth of what you've shared with us, and you've definitely, I can feel that you've sparked a lot of thought and consideration in our space here. So
Thank
thank
you
you,
so much.
Elsie.
Thank you,
Yeah,
everyone. Have a wonderful, wonderful day.
thanks. You as well. I'm
Uh,
going to remember to stop recording now here.